Bismillah ar-Rahman ar-Rahim. The topic of our lecture today is malignant ovarian tumor. Learning objectives. We will learn how malignant disease of the ovary, fallopian tube, and peritoneum presents. At the end of the lecture, we'll learn how ovarian cancer is investigated and staged. And also at the end of the lecture, we'll learn how ovarian cancer is managed. Background. Ovarian cancer is the second most common gynecological malignancy and the major cause of death from gynecological cancer. If detected in its early stage, ovarian cancer has an excellent prognosis, but bad prognosis of ovarian cancer attributed to the following. Number one, no signs and symptoms specific for it makes its detections late. Screening has not yet been shown to be effective. Figo staging differ from other gynecological tumor in the form of bilaterally seen in stage 1, rupture ovarian capsule is seen in stage 1, spreads by different route by peritoneal fluids, by blood spreads, and by lymph nodes locally up to the para-aortic lymph nodes. And finally, there have been few advances in the development of targeted treatments for advanced disease. The incidence of ovarian cancer. The lifetime risk of developing ovarian cancer in the general population is 1 in 70. And the mean age of presentation is 64. It is more prevalent in higher income nations. There are variations in incidence with ethnicity. White women have the highest incidence, whereas Asian women have a lower incidence. Ovarian cancer is rare in young age group, and account of only 3% of ovarian cancer occur in women under the age of 35. It is now increasingly accepted that a large proportion of ovarian cancer may in fact originating in the fallopian tube rather than the ovarian surface epithelium, as previously thought. There is significant genetic aspects to ovarian cancer. It is recognized that women with hereditary cancer present a little bit earlier, with a mean age at the time of diagnosis is 54, 10 years, around 10 years earlier. Coming to the pathological classifications of ovarian cancer, as we mentioned in the previous lecture, those arising from the surface epithelium, those arising from the stroma, sex-core stromal tumor, and those arising from the germ cells. We call them germ cells tumor, as we mentioned, whether benign or malignant. Now, histological classifications of malignant ovarian tumor, we have first of all, we have the epithelial ovarian tumor, which constitute around 80% of ovarian cancer and includes high-grade serous, endometrioid, clear cell mucinous, and low-grade serous in the form of borderline. The second one, we have sex-core stromal tumor, which constitutes 10% of the cases and includes, as we mentioned previously, granulosa cell tumor, sertoli cell tumor, and gyneandroblastoma. The third one is germ cell tumors, which constitute around 10% of the cases and include dysgerminoma, endodermal sinus tumor, or we call it Rorschach tumor, and teratoma, mainly immature teratoma, and choriocarcinoma. And it may be even mixed. And the last one is metastatic, which include Krukenberg's tumor. Now, epithelial ovarian cancer, they are classified into type 1, which is mostly from endometriosis or fallopian tubal-related serous borderline ovarian tumors, and include low-grade serous carcinoma, endometrioid clear cells mucinous malignant Brenner, and serous carcinoma. And we have two, which mainly originate from the fallopian tube, and even it differ in the genetic predispositions, and include high-grade serous carcinoma, undifferentiated carcinoma, and carcinosarcoma. Coming to the epithelial tumors. Epithelial tumor of the ovary, as we mentioned, can be benign, malignant, or borderline. Borderline ovarian tumor constitute around 10% of epithelial tumor. They are well differentiated, has some features of malignancy as nuclear pleomorphism, cellular atypia, but do not invade the basement membrane. They spread to other abdominal pelvic structures as peritoneum and omentum, but do not often recur following initial surgery, making them of good prognosis. The majority of them are serous. Mucinous type may actually arise from appendicular carcinoma of low malignant potential and can be associated with pseudomyxoma peritonei. High-grade serous carcinoma account for around 75% of all epithelial ovarian cancer, while mucinous and endometrioid tumor are less common, accounting for 10%, followed by less frequent tumor, which is clear cell carcinoma. High-grade serous tumor are characterized histologically, as we mentioned previously, by concentric ring of calcifications called thymoma bodies. Now, mucinous carcinoma are generally large tumor, multiloculated tumor associated with pseudomyxoma peritonei usually. Endometrioid carcinoma are similar in histological appearances to endometrial cancer, associated with endometriosis in up to 10% of cases, associated with endometrial cancers in up to 15% of cases. They tend to be well differentiated and are associated with better survival than high-grade serous carcinoma. Lastly, we have clear cell carcinoma can also arise from endometriosis and are characterized histologically by clear cells, much like renal cancer. This picture shows atypical endometrioma with solitary papillary projections, maybe multilocular, maybe unilocular. And in these conditions, we have to exclude malignancy whenever we see endometrioma by ultrasound with these features. Coming to high-grade pelvic serous carcinoma. All high-grade serous tumor arising from the ovary, fallopian tube, and or peritoneum. Data from women with BRCA mutations have been undergone risk-reducing prophylactic bilateral salpingo-oophorectomy, suggesting fallopian tube to be a precursor for it. These precursors, we call it serous tubal intraepithelial carcinoma, and they are characterized by mutations in p53 in secretory cells of the distal part of the fallopian tube. As many as 30% of high-grade pelvic serous cancers have BRCA mutation, which has implications for the majority of women who present with apparently sporadic disease. Coming to endometrioid, mucinous, clear cell, borderline, and low-grade serous ovarian carcinoma, which is type 1 epithelial ovarian cancer, they are ovarian in origin. The origin of these tumors involves drivers mutations in different types of genes than high-grade. The clinical distinction between high-grade serous carcinoma and other type is important. Why? Because differences in disease progression, response to chemotherapy, and even there is differences in the prognosis. Coming to the risk factors of ovarian cancer, those increase and those decrease. We see that decreased risk of ovarian cancers is seen mainly with multipara women, those using combined oral contraceptive pills, and the reduction may be up to 50%. And we have those undergoing tubal ligations, salpingectomy, and hysterectomy. They have a significant decreased risk of epithelial ovarian cancer. While an increasing risk of ovarian cancers goes with nullipara women, with endometriosis, using device, endometrioid contraceptive device, cigarette smoking, and we have obesity. What are the genetic factors associated with ovarian cancer? 10 to 15% of women with epithelial ovarian cancers have hereditary predisposition. Women with mutations in BRCA1 and 2 and Lange syndrome have an increased lifetime risk of epithelial ovarian cancer. The lifetime risk increased to 1 in 7 in the general populations, up to 1 in 20 If women have one family member affected by a defect in one of these genes, and increase up to 50% if two first-degree relatives are affected. Hereditary cancer usually occur around 10 years earlier. I mean, they present earlier and are associated with other cancers as breast, colon, and rectum. The most common hereditary cancer is breast ovarian cancer syndrome. This is called BRCA, as we mentioned, accounting for 90% of hereditary cancer. This syndrome is due to mutations of tumor suppressor genes BRCA1 in up to 80% and 2 in up to 15% of cases. While Lyme syndrome is hereditary non-polyposis colorectal cancer and is associated with endometrioid cancers and 10% lifetime risk of ovarian cancer. Hereditary ovarian cancers tend to be by histopathology adenocarcinomatous. They present in later stage with the exceptions of lung-associated tumors. They present earlier. Recent evidence supports improved survival, probably due to a better response to chemotherapy, mainly platinum type. Screening using transvaginal ultrasounds with tumor marker has not been shown to improve survival in women with familial predisposition to ovarian cancer. Why? This is because the high-grade serous tumor that are associated with BRCA mutations carrier status develop rapidly, and most are at an advanced stage before they can be picked up by screening. Is there any preventing measures for this type of ovarian cancer? Women who test positive for BRCA mutations are offered, number one, risk-reducing prophylactic bilateral salpingo-oophorectomy when they have completed their families. This can usually be performed laparoscopically. Prophylactic surgery reduces ovarian cancers by 90% and breast cancers by 50% in premenopausal women, although it does not eliminate the risk of primary peritoneal cancer. It is important to carry out risk-reducing surgery prior to the age-related surge in women in ovarian cancer observed in BRCA mutation carrier, which is in young women, preferably to be performed in BRCA1 in mid-30s and in BRCA2 in early 40s. Number two, another suggestion for preventing ovarian cancers comes from the theory that BRCA-associated ovarian cancer actually originating in the fallopian tube rather than the ovary. Hence, performing bilateral salpingectomy with delaying oophorectomy in the 30s and early 40s may offset the morbidity associated with surgical menopause in young women while reducing the risk of cancer. But this strategy has yet to be subjected to rigorous testing and its efficacy is unknown. Recent data indicate that opportunistic removal of fallopian tube during hysterectomy for benign indication also reduces the risk in women at average lifetime risk of ovarian cancer. Other procedures associated with ovarian cancer risk reductions including tubal ligation and hysterectomy with ovarian conservation. Chemoprevention using combined pills reduced ovarian cancer risk by up to 50% in both BRCA mutations carrier and women at average risk of ovarian cancer. How the woman with ovarian cancer presents. Most women with ovarian cancer have symptoms, however, these symptoms are non-specific and often vague. The difficulty with the clinical diagnosis is the main reason that patients with ovarian cancers present with late-stage disease. 66% present with stage 3 disease or even greater. And this has a dramatic effect on survival by default. The most common symptoms are increased abdominal girth, bloating, persistent pelvic and abdominal pain, difficulties in eating and feeling full quickly, other symptoms such as changes in bowel habits, urinary symptoms, backache, irregular bleeding, and fatigue. By examinations, pelvic and abdominal examinations may reveal a fixed hard mass arising from the pelvis. I mean, it is a pelvic tumor. The differential diagnosis of this pelvic tumor include non-epithelial ovarian cancer, tubo-ovarian abscess, endometrioma, and fibroid. In combinations with the presence of ascites, a diagnosis of ovarian cancer is highly likely. It should be noted that less than 20% of adnexal mass in premenopausal women are found to be malignant, and 50% in postmenopausal women are found to be malignant, as we mentioned previously. Chest examination is mandatory to assess for pleural effusion, and the neck and groin should be examined for enlarged lymph nodes. How to diagnose and what are the investigations to be undertaken? Transvaginal ultrasound is the initial imaging modality of choice to check for pelvic pathology. The investigations of any pelvic mass include the measurements of a tumor marker. This is the second most important line of investigation. Tumor markers used in ovarian cancers in the diagnosis and mostly in the follow-up. And the tumor markers are, we have mostly CA125 and CA19.9, which are seen mainly in epithelial ovarian cancer, and they are important for the follow-up. Now, inhibin, they are mainly seen with granulosa cells tumor. Beta-HCG are seen in dysgerminoma, choriocarcinoma, and embryonal carcinoma, but mainly in choriocarcinoma. Alpha-fetoprotein are seen with yolk sac tumor and in immature teratoma, embryonal carcinoma, and rarely with sertoli-Leydig cells tumor. Lastly, lactic dehydrogenases are seen in where? In dysgerminoma. And these tumor markers is very important for the follow-up, as we mentioned previously. Coming to the most important one seen and measured with epithelial ovarian cancer is CA125. It is non-specific tumor markers. It is elevated in more than 80% of epithelial ovarian cancer, but it is only increased in 50% of early stage epithelial cancers. As we mentioned, it is non-specific, so it can be seen with other conditions as pregnancy, endometriosis, and alcoholic liver disease. Now, the most important thing is the contributions of these tumor markers with risk of malignancy index formula, which depends on menopausal states, pelvic ultrasound features, and CA125, as we mentioned previously. And according to this index, we can classify the patient into low, intermediate, and high risk. To triage pelvic mass into low, intermediate, and high risk of malignancy, we depend on this risk of malignancy index. Pelvic pathology at intermediate or high risk of malignancy is further imaged using CT and or MRI. The benefit of CT is for assessment of extra-pelvic disease and for staging, while the MRI scan helps define tissue plans and the probabilities of this ovarian tumor. Other investigations before surgery include chest X-ray, ECG, full blood counts, urea creatinine, and liver function tests. If the patient presents with ascites or pleural effusion, paracentesis or pleural aspiration may be required for symptom relief and for diagnosis. How? A sample of fluid removed is sent for cytological assessments. If the diagnosis is uncertain or if a primary chemotherapy is being considered, a biopsy is mandatory before treatments. This is performed laparoscopically or radiologically using ultrasounds or CT. And the omentum is a very good site for biopsy. How to stage? Ovarian cancer staging is based on a clinical pathological assessment. And like other cancer, it depends on FIGO staging system. Overall, 25% of patients, they present with stage 1, 10% with stage 2, but mostly with stage 3 up to 50%, and 15% with stage 4. Women with early cancers, mainly stage 1 and 2, have up to 20% metastasis suppressed to lymph nodes, while this increased to 60% in advanced disease stage 3 and stage 4. And this slides show International Federations of OB/GYN staging of ovarian cancer. The treatment of choice in ovarian cancer is surgery. Objective of surgery is to stage accurately the disease and remove all visible tumors. The surgery should be complete or optimal cytoreductive. We call it cytoreductive surgery. What does it mean? It means less than 1 cm of residual microscopical disease is left behind. If the patient is at high risk of ovarian cancer, the surgery should be performed in gynecological oncology units, as this shown to be improved outcome. How to do it? Vertical incision is recommended. Ascites or peritoneal wash should be done. Total abdominal hysterectomy with bilateral salpingio-oophorectomy and omentectomy. And further debulk may be required, possibly including resections of bowel, peritoneal stripping, or even splenectomy in order to remove all tumors. Lymph node resection is very important, particularly in early stage disease, where studies have found occult metastatic disease in node in up to 20 to 25% of patients with stage 1 tumor. What is the meaning of fertility sparing surgery? This is very important. It means unilateral salpingio-oophorectomy, omentectomy, peritoneal biopsy, pelvic and para-aortic node dissections can be performed with endometrial sampling to exclude synchronous tumor. The indications of it: young patients who are found to have an early stage epithelial ovarian cancer wish to have conservative surgery, and borderline tumor if fertility is an issue. If a patient is unfit or unwilling to have surgery, or if preoperative assessment indicate that complete debulking surgery is unlikely to be achievable, primary chemotherapy may be justified. If the patient responds to chemotherapy, then interval surgery can be carried out after 3 cycles of treatments. Recent studies indicate that this strategy may reduce postoperative morbidity, yes, but does not influence survival. What is the meaning of second look surgery? Second look surgery is a planned laparotomy at the end of chemotherapy. The main function is to assess and resect any residual disease. Data on second look surgery indicate no survival benefits, and consequently it is not standard management outside clinical trial. Following surgery, how to follow? All patients with a diagnosis of epithelial ovarian cancer should be discussed at gynecological oncology multidisciplinary team meeting, where their history, surgical managements, histology after it's come, reviewed by gynecological oncologists, radiologists, pathologists, and even nursing staff. If the cancer has been properly staged as stage 1A or B and histologically of low grade, it means well or moderately differentiated, chemotherapy may be withheld. But the role of chemotherapy in stage 1C disease is uncertain. But in practice, we call good practice point, most patients will be offered post-operative chemotherapy in this stage, as with all other stages of epithelial ovarian cancer. Coming to the chemotherapy, which is again a cornerstone line of treatment with ovarian cancer. Chemotherapy can be given as primary treatment, as an adjunct following surgery. For relapses of a disease, it can be used to prolong clinical remissions and survival, or for palliation. First-line treatment is usually a combination of platinum compound with paclitaxel. First line, so it will be platinum compounds. They are the most effective chemotherapeutic agents in ovarian cancer. They are heavy metal agents that cause cross-linkage of DNA strands, thus arresting cell replication. Carboplatin is now the main platinum compound used, as it is less renal toxic and causes less side effect, but is equally effective as cisplatin. The dose of carboplatin is calculated according to the glomerular filtration rates. Most regimens are given as an outpatient basis, 3 weeks apart for 6 cycles. Second line, we have paclitaxel, is derived from the bark of the Pacific yew. Works by causing microtubular damage to the cell. This prevents replications and cell division. We use the steroids before treatments because it is highly sensitive. It carries a high sensitivity reaction. Side effects of it causes peripheral neuropathy, neutropenia, myalgia, and the total hair loss, mainly whole body. It is irrespective of those independent. Third line of treatment, we call it bevacizumab. They are a monoclonal antibodies against vascular endothelial growth factor. That's why it inhibits angiogenesis. It has been shown to be clinically effective in improving recurrences, free, and overall survival when given in combinations with carboplatin and paclitaxel in advanced ovarian cancer. The side effect profile of these drugs include hypertension, delayed wound healing, GIT perforations, and arterial thromboembolic events, so they are major. This drug is not routinely prescribed as first-line treatment for advanced ovarian cancers on National Health Service. Why? Because of cost issue. However, it is available for the treatment of recurrent disease. Following completions of chemotherapy, patients have a further CT scan to assess response to treatment. So we will do CT scan after we complete chemotherapy. This scan can be used for comparison in the future if there is clinical or any biochemical evidence of recurrences. And also the follow-up will depend on the clinical examinations and tumor marker with CA125. The prognosis of epithelial ovarian cancer will depend on stages of the disease, volume of the residual disease after surgery, histological type and grades of a tumor, and the age at the time of presentation. And this stage, according to FIGO, shows the 5-year survival rate. It is the best with stage 1 and the worst by default with stage 4. What is the meaning of primary peritoneal carcinoma? It is a high-grade pelvic serous carcinoma. It is histologically indistinct from tumor arising from the fallopian tube or ovary. There are morphological differences between the two groups based on clinical findings at the time of laparotomy. How? Criteria for diagnosis include the ovaries, we will see it normal size or slightly increased, more extra-ovarian disease than ovarian disease per se, and low volume peritoneal disease. The clinical behavior, prognosis, and treatment is the same as for other high-grade pelvic serous carcinoma, although there is a trend toward using primary chemotherapy as complete surgical debulking is very difficult in this type of a tumor. Coming to the second type of ovarian cancer, we call it sex-core stromal tumor. These tumors account for approximately 10% of ovarian tumor, but almost 90% of all functional ovarian cancers, or we call it hormone-producing tumor. Generally, they are tumor of low malignant potential with a good prognosis. Some morbidity may arise from the estrogen as granulosa, theca, or sertoli-Leydig cell tumor, or androgen as sertoli-Leydig cell tumor. By it they manifest and causing precocious puberty, abnormal menstrual bleeding, and by default this will increase the risk of endometrial cancer. The peak incidence of it is around menopause, although There is one type of it we call juvenile granulosa cell tumor, usually presents in earlier, even less than 10 years, and it is one cause of precocious puberty. Overall, granulosa cell tumor are the most common subtype, accounting for more than 70% of sex-cord stromal tumor. How the woman with these tumors presents? By hormonal production manifestations, by big size male granulosa cell tumor, or by complications as torsions or hemorrhage, sertoli-Leydig cell tumor by androgenic manifestations, or again by its size. Most sex-cord stromal tumor present as unilateral ovarian mass, even may reach up to 15 centimeter in diameter. Macroscopically, as we mentioned previously, usually it is yellow in color because of steroid productions from it. Now, how to treat? Treatment is based on the patient's age and whether the woman wishes to be pregnant or not. If the patient is young, unilateral salpingio or oophorectomy with endometrial sampling and staging is sufficient. If she is old, full surgical staging is recommended. Granulosa cell tumor can recur many years after initial presentation, as we mentioned, and required long-term follow-up. Recurrences is usually well-defined, and surgery is the mainstay of treatment at that time, as there is no effective chemotherapy regime in this type of tumor. Coming lastly to the germ cell tumor. Malignant germ cell tumor occur mainly in young women and account for approximately 10% of ovarian tumor. They are derived from primordial germ cells within the ovary, and because of this may contain any cell type. The emphasis of management is based mainly on fertility-preserving surgery and chemotherapy. Why? Because it occurs, as we said, in young age group. The most common presenting symptoms are as mass, we have as complications, and may present during a pregnancy because it occurs in young age group. 70% of germ cell tumor are stage 1, and the mode of spread is mainly by lymphatics or by bloodborne. Type: dysgerminoma is the most common, account for 50% of all germ cell tumor. They are bilateral in 20% of cases, and they secrete HCG and inhibin. And lactic dehydrogenase. Endodermal sinus yolk sac tumor are the second most common germ cell tumor, accounting for 15% of cases. They are rarely bilateral, unlike dysgerminoma, and they secrete alpha-fetoprotein. They present with a large solid mass that often cause acute symptoms as torsion or rupture, and the spreads of it mainly by blood, the spreads of it mainly to the lungs, and it occurs as a late events. This picture shows dysgerminoma and endodermal sinus tumor. The third type is immature teratoma, account for 15 to 20% of malignant germ cell tumor, and about 1% of all teratoma. They are classified as mature or immature depending on the grades of neural tissue presence. 1/3 of teratoma secretes again alpha-fetoprotein. Occasionally, there can be malignant transformation of cell type within a mature teratoma. The most common cell type to transform is squamous cell carcinoma. Lastly, it is called non-gestational choriocarcinoma, and it is rare, usually presenting in young age group, and they present with irregular vaginal bleeding and very high level of beta HCG. This picture shows immature teratoma, and the second shows non-gestational choriocarcinoma. How the woman presents. Germ cell tumor should be suspected if a young woman presents with a large solid ovarian mass, especially if it is rapidly growing. Tumor markers are measured preoperatively, as this may influence the need for postoperative chemotherapy. MRI is helpful to assess morphology, especially with teratoma. CT scan of the abdomen allow assessment of the liver and lymph nodes to be involved or not. All patients should have chest X-ray to exclude pulmonary metastases. How to treat? Surgery is tailored to suit the patients. As most women present with malignant germ cell tumor are of reproductive age group, so fertility-sparing treatment may be preferred. Explorative laparotomy is performed to remove the tumor and assess contralateral suppressed to the other ovary, mainly in this germinoma. If there is a cyst present on the other ovary, this should be removed as well. Careful inspections of the abdominal cavity is required with peritoneal biopsy and sampling of any enlarged pelvic or para-aortic lymph nodes to be performed. If metastatic disease is found, it should be debulked as surgery. Intraoperative frozen section, if it is available, may be required to assess nodal status. Postoperatively, postoperative chemotherapy will depend on the stage of a disease. Stage 1 dysgerminoma and low-grade teratoma are treated by surgery alone, and the 5-year survival rate for both of them are excellent. For the reminders of the tumor and for patients with disease outside the ovary, chemotherapy is given. And the most common regime used is a combination of bleomycin, etoposide, and cisplatin, BIP, given as a course of 3 to 4 treatments, 3 weeks apart. This regime gives long-term recure rate of over 90% of cases and also preserve fertility if required. If the patient has recurrent disease, 90% will usually present in the first year following diagnosis. Salvage chemotherapy has very good success rate. Thank you so much.